Everyone, I'm Freya Tracey. I'm a senior data analyst at the Health Foundation, and I'm here with Rhian. Do you want to just say hello?
Hi, so my name's Rhian. I work at the Office for National Statistics, and I'm a senior researcher there.
So today we're both going to present on some work on changes in self-reported health over a decade. I am going to present the background to changes in self-reported health that we saw between 2011 and 2021, the findings from this analysis, which we're focusing on the working age population today and how these relate to the public health conversation. And Rhian is going to present the analytical methods that were used in the research. We're both happy to take clarifying questions throughout, and we'll leave plenty of time for discussion at the end. Really keen to hear your thoughts, particularly on maybe how these findings from a national analysis might relate to what you might be seeing at a more regional or local level. So starting with some background about self-reported health. Self-reported health is an important measure of the public's health. It's a subjective measure and it's based on individuals evaluating their own health status, and it isn't collected as part of NHS health records. It goes beyond defining health by the diagnosis of health conditions. We know that diagnosed conditions don't match the true prevalence that we see in the population. And we also know that these health conditions can affect people in different ways, including how well they feel able to manage their conditions and the support that they can access. Self-reported health is used as part of the way that we calculate healthy life expectancy, or rather the ONS calculate healthy life expectancy for us, alongside life expectancy. Now, healthy life expectancy is a key focus for the current government, and they've made a commitment to halve the gap in this between the poorest and richest areas. You might have seen quite a lot in the press recently when new healthy life expectancy data at national level was published towards the end of February, I think it was. So healthy life expectancy is a kind of a hot topic, both because of the government commitment and the recent publication on this. And the census gives us a unique chance to see how everyone in England views their health, which is something that we usually estimate from surveys, which have much lower participation and carry the obvious limitations that survey data collections do. But with the census, we've had a chance to ask everyone in England how they view their health in general. And people are asked this across a 5-point scale, from very good to very bad. So we look at very good and good as defining as good health. Then we have fair, bad and very bad as what we define as not good health. So the census is this kind of unique opportunity to understand self-reported health, and that's kind of what catapulted us into this analysis. So the work that we're presenting on today is work that the Health Foundation commissioned from the ONS, who have unique opportunities to link census data. And there were 2 phases. So this graph is from the first phase of work, where we looked at how this differed between 2011 and 2021. People's perception of their health changes throughout the lifetime, which we can see as age increases along the x-axis, with the columns getting shorter in both time periods. So 2011 is the blue bar and 2021 is the red bar. That kind of matches up with what we would expect to see, is that a smaller proportion of the population report themselves to be in good health as people age, with comorbidities more likely to occur as people age. So in 2021, we saw that 91% of 20 to 39-year-olds reported being in good or very good health, so that's the red bars, compared with 56% of those aged 70 to 89. Now, overall, we saw 1% more people reported being in good health in 2021 than in 2011. So that feels like a good news story. But despite this overall increase, we saw some findings which did seem concerning, with fewer younger working age people, so those aged 16 to 40, reported being in good health in 2021 compared with 2011. So you can see the red bars sit slightly lower than the blue bars in the younger age groups. But more positively, we saw the older age group showed the opposite trend. So we saw higher red bars than blue bars in 2021. So following on from the first stage of the analysis done by the ONS, we then commissioned the ONS to look at how self-reported health changed at an individual level rather than at a population level. This was with the aim of understanding how the changes people reported were associated with, I've gone forward too fast, were associated with the demographic and socioeconomic factors that they reported in 2011, so what we might call baseline within an analytical context. The analysis looked at changes for each of those who said they were in good or not good health in 2011, and the factors associated with these groups reporting being in good, not good health in 2021 or dying before 2021. And Rhian will explain to you about how the data linkage made this possible. So in the Health Foundation briefing, which you may have read, and I'll discuss more in a minute, we focused on changes from 2011 to 2021, and those are the findings that I'll present on today. I'll now hand over to Rhian to talk about the methods.
Great, thank you, Freya. Yeah, if you could click to the next slide. And I just want to say I'm really happy to take questions throughout. I just had a quick check. I can't see the chat. So if you are happy to put your hand up or shout or whatever, please do, because I know that data and methods can be a little bit tricky and off-putting. So if there's anything I can do to clarify as we go through, please do let me know. And there's no such thing as a silly question. It's good to clarify what we're doing here. So in terms of the approach, we started out with Census 2011, and we linked the respondents on an individual basis to Census 2021 responses or to a death registration. So where there wasn't a corresponding Census 2021 health status or a death registration, that small number of unlinked were removed from our study population. And the way we were able to do this was to link using an NHS number. So for Census 2011, we used the patient register, and more recently have had access to the patient demographic service. More than happy to send a bit more info if people really want to get into the weeds of that. The linkage rate was 94%. So what that means is for our population of interest, after removing imputed cases, so in any census, it is a household national survey, and there's a very small amount of households for whom we don't get a response, and there will be a small amount of imputation. So after removing those, the linkage we had with NHS number was 94%, and we did similar then with 2021 so that we could attach and link people from across the two censuses. So in terms of the population of interest, we were interested in usual residents in England. We did actually produce the same results for Wales, and Welsh Government did do a small headline summary on that. Again, more than happy to send some information on that. Appreciate this is a Midlands forum, so you're probably less interested in the Wales results, but just in case there's a tiny bit of interest, I can do that. So our population of interest was people who were living in England and usual residents. What that means is people whose main residence is in England. They weren't here on a holiday or something like that at the time the census was taken. People who were aged 16 to 90 years in 2011 and had either completed both censuses or had a death registration between Census 2011 and Census 2021. So the point of our models and what we were aiming to do was to use the socio-demographic characteristics of the Census 2011 population to predict the odds of a change in health status or remaining in the same health. So whether that was remaining in good health across the two time points versus moving into not good health or a death status, and then similar then for not good health. So when you look at the odds in the results, we're comparing a change in health to no change. So after we had defined the population, we then stratified. So you will see that the models are, there are 4 models for each aspect that we're looking at, because we look at groups by sex, so males and females, and then also by the 2011 health status, so that we can predict the odds more fairly than if we were to group everybody together. And I'm just checking if there is anything else. So the reference group generally that we used was either the most frequent category, or it was generally based on our knowledge of the domain and what felt appropriate there. So if we can move to the next. So this is talking around the limitations, but first of all, I guess the strengths of the data and the methods that we use we've used whole population data. So by using the census and the linkage, we're able to get huge coverage of the population and feel the results are therefore a lot more representative of the subject area and change in health, in self-reported health. We had very high linkage, as I said, because we were able to use the patient demographic service. The linkage rates were in excess of 90%, which is very, very strong. So there's very small missingness or unlinked cases between those time points. And the census is regarded as high quality survey data. In terms of the limitations, then the first limitation is around causal inference. So the data and the method do not support causal inference. What I mean by this is because we have taken data at 2 cross-sectional points, well, 1 point for the 2011 demographics that we looked at, and we don't have any data collected on the in-between points, we cannot say that deprivation in 2011 causes ill health in 2021. So that's an important thing just to unpack. We are able to talk about associations, and that's what Freya will talk to you around, is what are the characteristics and how are they associated with health later on. And that's fairly standard for the type of data and the methods that we're using. Missing or variables that are not available, so we're not able to model health behaviours, access to healthcare, underlying health conditions. They've not been considered in this. They would have quite a strong they would likely have a strong association with health across the 2 time points, and the reason we can't do that is because we've used census data, and census data do not collect information on those areas. Another limitation, so I talked around where we have data in 2011 from an individual, but we don't have a corresponding death registration or 2021 time point. So this will typically relate to people who migrated out of England at that time. And so, for example, students from overseas or migrant workers who came in typically have very good health outcomes. They will not be included in our results. So if you were to look at the whole population of England at that point, it's possible that the results might be slightly different. So that's a limitation to be aware of. We are only looking at people who were present in both or had died in the UK. And yes, also worth noting that the pandemic may have affected how people perceive their health and how they responded. Having said that, we do see a lot of consistency. So, for example, in the overall results and that overall improvement, particularly at those older age groups that Freya was talking around, we do see some consistency with how people responded to the disability question in the census and in other survey that we are performing. So if anyone does have any questions, I'm more than happy to take those, or if I can provide any information on some of these, please let me know. I think we're good. Right.
I don't see any hands at the moment, but I will let it percolate in people's brains, and we can always pick up questions as we go along. Maybe once we've got into the results, people will be like, but how does that work? Yeah, thanks. I'm going to focus on the factors associated with no longer reporting good health. So as Rhian explained, we looked at the transitions for each of people who were in good and not good, and then the 3 outcomes that they could have. We have focused on the no longer reporting good health, so that's going from good to not good health, just in the working age population. There's loads more to dig into in the ONS data release on this, and I would really encourage you to have a look at what might be of most interest to you. I just couldn't write it all up into one briefing, but as nerdy as it may sound, I had a really good time going through all the results and trying to work out what to focus on. So I would definitely encourage having a look at those results too, if you are analytically minded. So starting with age, as we saw in the first chart with the red and blue bars, and as we would expect, age is related to reporting being in good health and continuing to report being in good health a decade on. So on the left Sankey chart on this one, we've got people who are aged 16 to 29 years old in 2011, whilst on the right are people aged 50 to 69 years old in 2011. So at baseline, we see a lower proportion of those aged 50 to 69 in good health than the 16 to 29 age population. So that's the chunk of blue on the left-hand side. And when we look at the transition into no longer reporting good health in 2021, so that's going from the chunk of blue on the left-hand side into purple, so you see that kind of bluey, purpley fade, we see that around 1 in 20 of those aged 16 to 29 no longer report good health, so go from blue to purple. But we see this is much higher for those aged 50 to 69 years old. So that's about 1 in 6 of those in the blue on the left-hand side go to purple. So we know that age is a strong determinant, but it's interesting to think about this across deprivation. So here we have along the x-axis the age groups, and on the y-axis we have the percentage who transition from good to no longer reporting good health. So as we saw with the Sankey charts, as people age, their likelihood of no longer reporting good health increases. But here we can see a clear difference across deprivation quintiles, with a higher risk of no longer reporting good health at every age group for those in the most deprived decile, which is the red line, when compared with those in the least deprived decile, which is the blue line. And across all of the ages, across both sexes, we see that this is at least a 43% higher risk between the two groups. And this is after accounting for differences in ethnicity, household tenure and composition, as well as employment. So it means we can begin to see the effects of living, or the associations with living in more deprived areas, separately from the demographic and individual socioeconomic factors which might co-occur with these different deprivation quintiles. So what we can see is that the percentage point difference widens towards the older age group. So you can see the red and blue bars are getting further, lines are getting further and further apart as the age groups increase, as at 2011. And this highlights the cumulative impact of the experiences people have living in more deprived areas. So we can see that that absolute percentage point difference widens as you increase the age group. And on the flip side, we see that the relative difference, because the numbers are smaller, but the difference is larger, if that makes any sense at all, the relative difference sits higher when we look at the younger age group. So on the y-axis here, you've got the relative difference. Now we see younger age groups see this high relative difference, and the sexes look quite similar, but it remains slightly higher for females than males towards the older age groups. So females aged 20 to 24 in 2011 who were living in the most deprived quintile had a 72% higher risk of no longer reporting good health compared with the least deprived quintile. Now, this relative difference reduces to 57% higher for females who were aged 55 to 59 in 2011. Now, that age group would have been 65 to 69 in 2021, which is the period during which people reach state pension age. We also, for males, this was similar at 51% higher risk. And this shows that people living in the most deprived areas are at much greater risk of being unable to maintain good health to state pension age than those who live in the least deprived areas. And this inequality is a concern for the planned rise in the state pension age, which will increase to 67 from April 26. So I wrote this in February, so that's now, and future potential rises. Any further increase risks widening existing inequalities if people are unable to work due to ill health, which means relying on the less generous working age welfare system than they would otherwise receive if the state pension age hadn't increased. And we're going to see that inequality across deprivation levels, as shown by the previous graph. So after looking at age and deprivation, we then looked at economic activity and household tenure as individual level characteristics. And we looked at different types of economic activity, and those tell us whether or not someone is in employment, and if not, for what reason. And here we focus on the health changes seen for people who were not in employment in 2011. So people might not be in employment, but economically active, which is what we would define as unemployed. So that means that they're not working, but they are looking for work. And they would be able to start work within the next 2 weeks. And then we've also got people who are economically inactive. Here we've only looked at people who are long-term sick or disabled, and people who are looking after their home, family, or another reason. People who are retired or studying are also classified as economically inactive, but we haven't included those here. but they are included in the ONS data release. So again, if you're interested in those groups, I would encourage you to have a look at the data there. We used people who are in employment as our reference category, and they were chosen because they are most likely to maintain good health, given the positive role employment can play on health. In this bit, we accounted for demographic factors, so that's age, sex, ethnicity, and the region of the country, as well as socioeconomic factors, so that's area level deprivation, which we've already seen makes a difference, highest qualifications, and household tenure and composition. And when we, after accounting for all those differences, what we can see is that females and males who were unemployed, so that's the blue dot on the graph, but seeking work, had a 67% and 82% higher respective likelihood of no longer reporting good health a decade later when compared to those who were in employment. What we see is that there is a similar level of inequality when we look at people who are economically inactive due to looking after family or home or for other reasons. So that's the purple dot here on the graph. But when we think about people who are economically inactive due to long-term sickness or being disabled, we see a much, much higher relative likelihood of no longer reporting good health when compared to people who are in employment. Females have a 272% higher likelihood, with males slightly higher at a 279% higher likelihood. So we don't see much of a sex difference, but we do see a huge difference when we compare being economically inactive due to long-term sickness or being disabled compared to being economically inactive due to looking after home, family, or another reason. It's worth noting, as Rhian said at the start, that this analysis only considers the employment status in 2011, and we don't track changes either over the decade or we're looking at the employment status that someone had in 2021. But what our findings do show is that the need to act early to keep people in employment is a preventative measure to protect their health, because we can see any reason for being out of work of the ones that we've got here and lead to a higher likelihood of no longer reporting good health when we're comparing it to people who are in employment. Then we also looked at housing tenure, which has fewer categories. We looked at people who are living in social or private rented housing, as well as people who are living in own tenure. We saw that both types of renting are associated with a higher likelihood of no longer reporting good health. And this was after accounting for the same demographic and socioeconomic factors before, but this time for accounting for economic activity status rather than household tenure, because that's what we're looking at here. We compared this to people who are living in own tenure, as this is the most frequent type of housing tenure within England. We saw that females and males who lived in private rented had a 42% and 34% higher respective likelihood. So there's the blue dots on the graph. And we see this difference increases substantially when we consider people who living in social rented housing compared to those in owned housing. We see a slightly higher difference for females at 92% higher likelihood versus males at 73% higher likelihood. So that's a lot of results. And as I said, this is only a small part of what you can find in the ONS data tables. I thought now would be a good chance to talk about how these findings link to the wider public health and policy landscape, as I know that not everyone will be analytically interested, and even those who are analysts, I think, are always interested in the so what of what this work can mean, as well as the graphs. I thought we'll start off with the preventative approach to unemployment. So being unemployed or economically inactive was associated with changes in how people perceive their health over time. We looked at people who viewed themselves to be in good health and were out of work due to long-term sickness or being disabled, and we saw they had a much higher likelihood. Now, often health inequalities among those not in work are assumed to affect people's state of health having already worsened. But what we can see here is that we have people who view themselves to be in good health, but are out of work because of their sickness or long-term sickness or disability. We know that the future growth in health-related economic activity could be 3 times greater than the growth in the working age population, both due to our ageing population and increasing multimorbidity. And this, combined with the findings that we have today, reinforce the need to keep people in work where possible through preventative measures. And these can include proactive sickness absence management and the introduction of vocational rehabilitation. If you're interested in this kind of approach, last year the Health Foundation published their Commission for Healthier Working Lives, which did lots of work looking at this kind of growing health-related economic inactivity and the types of actions that can be taken. So I definitely recommend reading that. This kind of approach can have positive impacts on both people's health and the economy. When we looked at housing, we saw that the insecurity of tenure in the private rented sector and the higher risk of overcrowding in both social and private rented housing might have contributed to the higher likelihood observed, but the findings with housing are a bit less clear, because whilst we have data on the type of tenure, we don't have data on the quality of housing, the number of people living in the housing, and so there's a lot more that would need to be understood about housing and their changes in self-reported health. We do know that the Renters' Rights Act will take important steps to improve the security of private rented housing, but won't be affecting social rented housing. And the improving housing affordability through the ambitious house building programme will take longer to take effect. That's one of the government's aims in order to improve housing within the country. And then, as I mentioned at the start, all of this work kind of links into the healthy life expectancy narrative that we're seeing through the government's commitment to halve the healthy life expectancy gap. So one of my colleagues, Andrew, published a blog recently, which you can access at this QR code, about what would it take to halve the gap in healthy life expectancy. And he had done some analysis to look at, whilst I mentioned at the start that self-reported health and life expectancy both inform healthy life expectancy, we wanted to understand what kind of weight each one carries, and therefore what is an important thing to focus on when we think about improving healthy life expectancy across the country, as well as reducing the gap. He found that for females, 79% of the gap between healthy life expectancy in the northeast, which is the region with the lowest healthy life expectancy, and the southeast, the region with the highest healthy life expectancy, is explained by self-reported health, and this is slightly lower at 74% for males, but still high. And what this tells us is that improving self-reported health will have the biggest effect on narrowing these regional gaps. And our work has shown that no longer reporting good health is associated with unemployment, rented housing, and living in the most deprived areas. So action across these building blocks of health will be needed to help people remain in good health, which will in turn promote healthy life expectancy. You can read Andrew's blog at that link. And here is an absolutely huge QR code, which will take you to the Health Foundation briefing. In that Health Foundation briefing, you can also find a link to the ONS data release, but otherwise, if you just Google changes in health ONS data release, you'll be able to find it and browse tables to your heart's content. Very happy to take any questions. I'm very keen to hear people's thoughts.
Thank you, Freya. Thank you, Rhian. That's really fascinating, and I'm very, very, very interested in this. I've also have set myself up yet again to invite questions in 3 different spaces, 4 if you include hands. So here I go. We have got some questions and some points as well. Let me just share my screen so we can just pick up on the first of those, which is let's just turn our attention to option number 1 for inviting questions from the audience and challenging the host today. So there are 2 spaces on Slido, and I'll get a hang of it. I used to use a different thing. And I'm getting the hang of Slido. So there are some questions on here, and there are 1 or 2 questions on the Q&A as well. So these ones, you may have covered them in what you have been talking about, because they arrive on here as you're still presenting. So the first one, if we just do them in turn, if that's okay. So the first one is housing. Some of these might be a yes, no, but is housing linked to being economically inactive?
So Freya, I'm happy to take that one. So from this piece of work, we wouldn't be able to say that. So what Freya has shown is the associations with health and housing, or health and economic activity. But in terms of housing and economically inactive, it's probably a fair assumption that for people who spend longer in economic inactivity, they're potentially going to have more access and higher rates of living in social rented, possibly than someone who's been in employment for a longer period of time. But definitely from this analysis, we wouldn't be able to talk about those linkages.
Yeah,
I would just add,
sorry, of course, yeah.
I was just going to say, I would add that because we in the economic activity one, we adjusted for different types of housing, and on the flip side, in the housing one, we adjusted for economic status. So you would kind of be removing that effect through the analysis as well.
Yes, sorry, that's right. I think I went off on a tangent then. So what Freya's saying is absolutely right. The figures that she's presented are after adjustment. So when we look at economic activity, that is after adjusting for differences in housing tenure. And when we look at housing tenure results that Freya's shown, that's after adjusting for differences in economic activity. And it's worth remembering as well that for deprivation, that we've adjusted there as well for economic activity status and for housing tenure. So those differences are by deprivation status.
Okay, thank you. So this question here, so it's picking up again. There's a couple on disability, but this one saying it's a similar question to the one that they can see below, slightly more specific. How large is the group of people who are economically inactive due to long-term sick or disability, but report in good health in 2011? And do we know anything else about this group of people as per your analysis?
Thank you to whoever asked this question, because this was something I was going to put on my slides and then completely forgot to. And as I was presenting, I thought, you didn't put that on your slides, Freya. So I promise this isn't a plant, but conveniently I've got the briefing up. So the numbers of people who are in good health or who reported being in good health but economically inactive are quite small. So in 2011, we had 159,000 people who reported being in good health and were out of work due to long-term sickness or being disabled, with 64,000 of that group no longer reporting being in good health by 2021. But for comparison, there were 962,000 people who were unemployed in 2011 who reported being in good health. So we see a much, much larger number who were in good health and unemployed than in good health and reported being and were out of work due to long-term sickness or being disabled. So the sample for that is much smaller. The results are still statistically significant, and we did the analysis at the England level so that we could have enough people within the analysis. So the findings are still meaningful, even though that population group is smaller. And the other question was, what proportion of adult population are economically inactive? How does this compare? So I think, so that one that I just read out was specifically about being economically inactive due to long-term sickness or disability. But these numbers are all in the ONS data release. And I would write them in the chat, but I can't access it. And then there's a question at the bottom about disability not changing due to being more black and white than health. Rhian, correct me if I'm wrong, but the question in the census is about being disabled within your day-to-day activities rather than being, it's about kind of how you view your own disability rather than it being a kind of binary term.
Yeah, that's true. So the questions are asked differently. So the health question is, I've got the census in front of me, and bearing in mind this is the census in 2011. I'm much more familiar with the 2021. How is your health in general? And then there are tick boxes for very good, good, fair, bad, and very bad. Now, the disability question is in 2 or 3 parts, and it's aligned to the Equality Act definition. So what people are asked is whether or not they have a long-term condition or illness. And then the next part is, to what extent does that long-term condition or illness limit day-to-day activities? Now, there were some prompts in 2011 that were changed in 2021. So if you are trying to compare disability status in 2011 and 2021, that is something to bear in mind. The main difference being that older age was a prompt in 2011. And it could be that part of the reason we're seeing a reduction in disability status at older ages is possibly due to the fact that that prompt was removed, although there do seem to be other factors that suggest that health is generally improving and is experienced better at older ages than what it was 10 years ago. Rambling a little bit, but you are right, there are differences in how those questions are asked, and one is more around, do you have disease, and does this disease limit you in your day-to-day activities? Not at all, limited a little, limited a lot. Whereas the health question is asking fairly subjectively, how do you rate your health in general?
Okay, thank you. Thanks very much. There's a couple more questions on here. Then I'll just double check the other screen afterwards, just to make sure that we're picking up as many of the questions as possible. But just to say, we will have the, if you will oblige, I would like to share anything that we don't get to afterwards, and maybe you could pick it up after the session. That would be appreciated. So there's a couple more here. They appear in the most recent ones which people have shared. So if we pick this one here, which says, either of you, this person thinks it's biased towards employment and housing. Does mental health, multi-morbidity, ethnicity, and environmental health factors, are they considered at some point? Is this something that is directly relevant to the way that you analyse the data? Can you answer that question?
So some of this, so ethnicity is included in the model, and there are results broken down by ethnic group, which we haven't covered today. Like I said, there's far too much to cover within one presentation. So I would encourage people who are particularly interested in the ethnicity results to look at those. You're right that we haven't factored in things like mental health and multimorbidity and environmental health factors because these aren't collected within the census. Some environmental health factors will be picked up within the deprivation quintiles, but obviously deprivation quintiles capture lots of different things. And so yeah, as Rhian said, these are looking at associations, and some of those associations might be related. Some of the drivers sitting under those associations might be things such as these, but they weren't things that we were able to include in the model based on what type of data we had collected within the census.
Yeah.
Okay.
And just to add as well, you know, the census doesn't collect data on mental health, multimorbidity, or environment health factors. So we would need other data sources and linking those in. So it's whether they're available or not.
Okay, thanks very much. We've got a hand up. Nathan, would you like to ask your question or share your comment, please?
Yeah, thanks. Thank you very much for this presentation. It's really interesting. So what you're looking at here is changes in people's self-reported health over a 10-year period. And one thing that could cause those changes is changes in people's actual health. Another thing that could cause those changes is people changing the way that they answer the question. So being more likely to say that their health is fair or good or not good, regardless of what their health status actually is. Have you done anything to try and control for that, or to check whether there are any differences in people's general manner of answering these questions between censuses? Were there kind of like control questions that were in there to assess that sort of thing, or have you been able to use other questions to kind of test possibilities around that? Or...
Sure. So across censuses, no, because then you'd need to identify individuals and yeah, try and sort of survey them separately. But within a census, yes, absolutely. So the ONS carries out a quality survey, and that is looking at the consistency in answering census questions, not just health, but all of the census questions. So one of the reasons that we've used a binary variable here, so good and not good health, is to reduce the risk of having differences in how people respond to the health question. So what the quality survey found is that people could actually change between the more detailed responses. So for example, good and very good, you could see people substituting those results on different days, and then sort of very bad and bad. However, broadly speaking, when you use the higher levels, the consistency is much higher in terms of how people respond. But do appreciate that, yes, it is a subjective question. It tends to be more on the detailed 5-part responses that we see differences than at the higher level. People are generally quite consistent as to whether their health is good, broadly speaking, or not good, broadly speaking. That quality survey is available online as well.
Okay. Thanks. Sorry, I'm just trying to follow. I don't know whether I explained my question very well. So if maybe say to give an example, you've got someone who you know has a generally positive outlook on life. You know, whenever you ask them how they're feeling, it's always great, it's always wonderful, always putting a positive spin on things. That's them in 2011. But by the time 2021 comes around, things have happened in their lives and now they're no longer so optimistic, and they tend to be much more negative in the way that they describe their feelings, their events, you know, things that have happened to them, that sort of thing. So, and of course, you'll have people who will go the other way as well, who get more optimistic and, you know, become more likely to agree that everything's wonderful. So you could have, you know, changes in the ratio of those two different types of people over the 10 years that could affect the results and potentially confound your interpretations of those results. Does that make sense?
I would say on this, I think it's worth, because I think everything you're saying is true and correct. And what I would say is that it's worth focusing on the fact that it is self-reported health. It's not that this is like a way of saying this is like, because we can define health in so many ways, this is one way. So I think it's almost, I think my way of understanding the analysis was thinking, well, let's welcome in those kind of that complexity of it and say that this is how people view their health. Almost sit it a little. We know that self-reported health is very well correlated with health. The ONS have done lots of work looking at self-reported health and morbidity, and I've got some links to that in the briefing. But in a way, thinking if we separate those out temporarily in our minds and just think this is about how people view their health, and it is that people are viewing their health worse, and we know that how people view their health largely correlates with what their more clinical defined health would be. But still, we're seeing that people are much more likely to no longer view themselves to be in good health. Now, that could be, like you say, due to temporary or long-term circumstances that are affecting them that can drive that. But all we can do is look at the baseline and look at that change. There is a paper that you might be interested in that is linked in the briefing, which looks at researchers who particularly looked at older adults reporting self-reported health during the COVID pandemic, and that may be having an effect particularly on older age groups, and that value judgment on health and how that can change based on kind of external factors. Again, I would link the paper, but I don't have access here. But if you can't find it, email me and I'll send it over to you.
Thank you.
Yeah, thank you for your question. I just take that. We've got a couple more questions before we got another hand up. Stephen, do you have a question?
Yeah, just a quick question. I work for a health company that deals with chronic fatigue syndrome and long COVID. And I was just interested to know, but what we've noticed over the last year is a noticeable decline in long COVID, and actually funding's been taken away from that. Although CFS, chronic fatigue syndrome, ME, whatever we call it, is still bobbing along. I was just wondering whether, I suppose you've only got 2011 and 2021, so you haven't got a nice graph, a line graph showing how the COVID has affected economic inactivity. Because I was just, I suppose I'm hoping, because one of the talks is a lot of people in the UK are economically inactive and not seeking work. And I think it's about 22%, 23% of the adult population, 16 to 24, are inactive but not unemployed, if you know what I mean. And another 5% are unemployed, which means that 74% are economically active. And therefore, one of the things I suppose to focus on, both for health and actually for the economy, is to maybe see if we can get some of those inactive ones back into work or seeking work. I don't know whether what you're doing has been feeding into that sort of debate, because of course it's a virtuous circle. If you're active economically, you're helping yourself, but you're also helping the country as well. And I suppose the government want people to get back to work. Is that all? Does that feed into all this? I suppose I'm asking.
Yeah, so there's a team at the Health Foundation who do a lot of work on the economy and health. As I mentioned, they did the Commission for Healthy Working Lives. They've also done a piece of work which might be of interest to you, which is about people who are not in education, employment or training. In fact, if people are interested in that, the Health Foundation and the ONS independently have both put out work recently. So I would recommend, there's lots to read there. The Mayfield review I would recommend looking at, which looked at people out of work and that being related to health. So the information I had about the 3 times high growth, that comes from the Mayfield review. So if you are interested in that, I definitely recommend looking at the Mayfield review, the work on needs.
Because it's a circular thing, isn't it, in a way? If you're economically inactive, does that cause ill health, or does ill health cause economic inactivity? The two are almost interrelated in some ways, aren't they? Because it's probably good for you to be out and about and working.
Yeah, that's what a lot of other Health Foundation work has shown, not from this work specifically, but I suppose the wider policy narrative is very much on that. Having people in work is a positive impact on health.
It's a good thing overall. The right job. Oh yeah, of course, sure. Yeah, thank you.
Great, thanks very much for responding. Thank you, Stephen. Right, so I've probably got time if I just sort of look at one more on the screen before we're drawing to a close. So I'm trying to pick some. I have to pick on this one, which starts off with "This is brilliant." I mean, why would I not? Because it is. I mean, it's brilliant work. So it's brilliant, as I've said. So at the Health Foundation and ONS, are you hearing less about the need to level up between the most and least deprived areas, or is that still the term that people are looking at?
I don't know how often I'm hearing the term level up. That's term specifically, but I would say that there is still a lot of focus on reducing health inequalities, particularly at the Health Foundation. There's a team led by Catherine Merrifield who looks specifically at the devolved power, and they're looking at like mayoral authorities and the kind of the power that mayoral authorities have when it comes to health. I think that's particularly interesting when we think about the kind of like, I suppose what we called a couple of years ago the levelling up agenda, and I feel like that term has kind of like
it's gone now.
It's gone now a bit, I suppose, with the government change.
Good. Glad about that.
But the kind of the sentiment behind it, I would say, is still there, obviously. Rhian, I don't know if there's anything else you wanted to add on that.
No, I agree. I think some of the more sort of recent government policy has been a bit more quiet on that term, like levelling up, and I think there's more of an interest around sort of labour market disengagement and economic activity, exactly actually as Stephen was saying, and what can we do to explore and hopefully prevent some of the longer cycles of economic activity that we're seeing, particularly in younger people. So yeah, it's a good observation that language does seem to have been more quiet recently.
It looks like Rachel may have frozen. Rachel, are you still there?
I know, I wasn't sure if I had frozen.
Maybe she's run off to have lunch.
Yeah, no, I think it's Rachel's. There's a question on the IMD, which I'm happy to take because I can take this quite quickly. Hopefully while Rachel's connection restores. So the question was around IMD and whether we removed the health domain. So there's a couple of health domains in the IMD in the index and how that's derived. We didn't remove the health ones for a couple of reasons. One, they're not directly related to the health question. So the issue would be, I guess, collinearity if you are plotting the same or similar predictive variables into the models. The health aspects of the index are around access to healthcare providers generally, which is different from asking people to self-report their health. The other is that when we've done sensitivity analysis using the IMD with and without in our modelling, typically it doesn't have much of an effect, on the effect. So we generally leave it in with health and disability, but it's a fair question and it's a fair point.
I saw Rachel leave. I don't know if she's going to rejoin. She might have updates about future huddles, but otherwise, thank you very much for joining and listening, and very happy to take questions by email if you have any more or thoughts to share as well. Okay, maybe let's leave it here now, and hopefully Rachel can share any future Huddle updates via email. Thank you, everyone. Have a nice Easter. Bye.
Thanks.
Thank you
Bye.
both. Bye.